And we welcome back Kwame McKenzie from the University of Toronto, where he's a professor of psychiatry. He's also medical director of diversity and mental health at CAMH. And you're here all this week, Kwame, helping us understand a whole bunch of different issues related to race and culture and the notion of the other. And tonight we're going to take a closer look at mental health and cultural diversity. And I want to start with depression. Can you give us some examples of how different cultures might regard and treat depression differently?
I mean, it's a very interesting question, partly because if you start off with different cultures, not every culture has a word for depression. The concept is not a universal concept. When you ask people what the most common symptom of depression is in here, people will say, depressed mood. You know, I feel depressed. Some people will say, I feel tired all the time. And actually feeling tired all the time worldwide is the most common symptom of depression. Thinking too much is another symptom of depression, or not having heart. And loads of countries just don't have this mind-body dichotomy. It's psychological problems or physical problems. It's holistic. It's part of a whole being.
Okay, we clearly in North America, particularly in the United States, I guess, not only have a word for depression, but it's a huge industry, and there are people who are, lots of people obviously taking medication for it. But give us an example of another country where the concept is perhaps less well known and, people are not medicated.
Well, there are most depression doesn't actually need medication. If it's mild depression, people often just need education, support, working through their problems. If it's moderate depression, you can use counselling, a special type of counselling called cognitive behavioural therapy, or medication. And if it's severe depression, you often do need medication. It's when you're looking at the mild and moderate depression across the world that people do different things. Some people meditate, some people do exercise. There's some evidence that certain types of yoga, especially yoga where people use breathing exercises, is particularly good for mild to moderate depression. Some people go to traditional healers, and those traditional healers will give them anything from placebos through to sort of certain rituals for the individual and for their family. And if you go to Germany, most people for depression, or a majority of people with depression, are treated with St. John's wort, which you can get across the counter from your naturopath here. And so across the world, people do things completely differently. Some people use family therapy, some people use individual therapy, some people use baths, and in some places, even in Canada, when you're looking at the Aboriginal population, people use sweat lodges and various other things. Depression has as many treatments as it has different guises, and different cultures do things differently.
Now, I'm just taking a shot here, but would the German approach to treating depression be that way? Because for some reason in that culture, taking medication for depression is just frowned upon, it's seen as weak or whatever, I don't know.
There are lots of reasons. I mean, certainly it used to be a third of Germans went to schools which were Steiner schools, which were built on the teachings of Goethe and Steiner. And they do tend to move towards naturopathic or homeopathic cures rather than allopathic cures, as modern medicine's called.
What would some cultural barriers be for those who did not want to seek treatment for depression?
Recognition is the first thing. Some people have symptoms that they don't recognize as depression. If you've got a culture that hasn't got a word for depression, you're not going to recognize that you've got depression. Then after that, it's a decision about who is the best person to treat it. Some people would want to go to their family practitioner. Some people would want to go to an alternative practitioner. And other people would want to go to the people who've been doing community care the longest in society. And that's religious people. So your priest or your imam or the elder in the Gurdwara are the people who've been counselling people for mild to moderate depression for longer than anybody else. And so not surprisingly, different people in different cultures will have different ideas in who is the best person. If you were a person who believed that you were low in your spirits and this was a spiritual problem, would you be wanting to go to a family practitioner who has 10 minutes for you, or would you be going to your priest? And that's how you have to think about the different choices that people want around the treatment of depression and other illnesses.
You're a Brit. I should ask you this because, of course, the British famous stiff upper lip suggested that, I'm sorry, we don't get depressed, on the other side of the pond. We just stiffen up our upper lip and we carry on. Did you find that when you lived there?
The Brits' stiff upper lip seemed to diminish, I think, with the increased Americanism of society and Americanization, let's say, with a Z.
Yes, not an S.
Not an S, with a Z
That's right.
of society.
Yeah.
But there's some interesting things about the stiff upper lip. There's some work by an interesting chap called Derek Summerfield around what happens or what has happened since people stopped using the stiff upper lip. And he's found that for soldiers and for people who've been traumatized, the rates of post-traumatic stress disorder have gone up. And he says that actually this idea of, mobilizing your own resources to deal with adversity and building resilience is actually quite important. And you have to have a balance between mobilizing your own resources and realizing when your own resources are not enough. So the stiff upper lip, and this is going to make me sound defensively British, isn't actually that bad a thing. It's just that people need to know when it's useful and when it's no longer useful.
Okay. Let me come at this from a different angle now. Racism. Does racism affect your mental health?
Oh, definitely.
How so?
Racism affects your mental health in many different ways. If something happens to you, say for instance, you don't get a job. I know that's probably never happened to you, but say it did happen to you. Okay, maybe it did, but we'll do your therapy afterwards. Say something happened to you, you didn't get a job. You'll be upset. That will lead to psychological changes, it will lead to physiological changes because you didn't get the job. It will lead to some anxiety. That's normal. Then you're lying in bed at night and you think, why didn't I get that job? And you think you didn't get the job because of your race. Then you've compounded your initial sort of level of anxiety and being upset with this extra level, which is, this is unfair, and that makes you really annoyed. Then there's another level. You can't do anything about it. So for each event, you have these three different things happening that's going to make you feel worse if you are being discriminated against. And that's what happens in racism. It's not just that you have a fight with someone, it's you then say, well, just a second, this was unfair and this was because of my race, and then there's nothing you can do about it. And so racism is really important with regards to producing stress, just on that individual level. But it's also important at another level. We found in studies that people who think or anticipate that they're going to be discriminated against or that they're living in a discriminatory world actually are more likely to develop mental health problems. So it's not just a racist act, it's also the idea that you're going to be discriminated against that causes a problem.
So it's beyond the initial disappointment. There's a compounding, if you like, of the consequences.
There's a compounding effect, and it doesn't necessarily have to happen to you. So if you see other people who are being discriminated against, then you can imagine you're thinking, that might happen to me. And then when you're starting to apply for a job, you start to be concerned. But then that job, and the reason for using a job is because the fact that you didn't get the job then has other consequences. It decreases your chance to move on, to get money, to get out of poverty, to get into a good house. And so the other effects are these economic effects. And those economic effects are, as we know, poverty, worrying about money, are all linked to developing mental health problems. So there's the effect of racism, there's a fear of racism, and then there's the impact of racism that it actually has on your chances in life, all of which are important.
Can the experience of racism influence the treatment that a patient may require?
That's a good question, because what we've generally done is ignored it. We've sort of said, well, a depressed person's a depressed person, so therefore let's treat the depression. The thing is, of course, if I've been a victim of racism and I am seeing somebody who I think doesn't really get it, or might be one of the people who's oppressed me in the past, that will change the way I interact with them. So it will change it will change my the therapeutic alliance, and the therapeutic alliance is really important for the outcome and the prognosis of any illness.
What about conversely? What about a situation where the person who experienced, let's use your example, the disappointment of not getting the job, maybe the person's a visible minority and thinks, damn it, my ethnic status probably had something to do with that, and then again the compounding takes place after that. But what if the person just didn't have the chops to get the job? What if they just weren't good enough? And there's a perceived racism that isn't there. How do you treat something that doesn't really exist?
There may not, I mean, you never know exactly. Something that's perceived, you don't know whether it happened or it didn't happen. The important thing usually in mental health is the person thinks it happens and thinks it's an issue. And actually when it comes to racism, there is quite a lot of evidence that it does happen a lot. And so it may have happened. But you might treat the illness. You also have to deal with the effects that people have had of victimization over time. And then you have to work out how you can build resilience, because there's quite a bit of evidence now showing that one of the important things that you need to think about with people who've been victims of racism, oppression, or discrimination in other ways is people have to learn to pick their battles. One of the worst things you can do is fight against all odds to try and have a success where success is never going to happen. And that will make you iller.
We know that there are people who are poor who have mental health issues, and there are people who are of racial minority backgrounds who have mental health problems as well. And when you put those two things together, is that quite a toxic mix?
Yes, I think that we're in a situation where there are these things that the Public Health Agency of Canada will call the social determinants of health. And that's poverty, that's unemployment, that's housing, that's being in a single parent family, that's living in a poor environment, and there are many others. And so we know that that increases, on average, people's chances of developing a mental health problem if they're exposed to the social determinants of health and mental health. If you're from an immigrant background or a racialized background or an ethnocultural background in Toronto, you are more likely to be exposed to the known social determinants. Then there are three other determinants: language, migration, and discrimination, on top of those other social determinants that give you an increased chance of developing a mental health problem.
As you make the checklist here, it sounds like we're a province of 13 million people, the capital city about 2.5 million people. It sounds like on the basis of that checklist, most of us have some mental health issues that we are dealing with at any given time in our lives. Is that fair to say?
Well, I think that we probably need to make a definition here between mental illness, which is problems that are sort of defined clusters of symptoms that are actually considered illnesses, like depression, like schizophrenia, like anxiety. And then mental health problems or difficulties, which we are going to come across because we are going to have to live in a society that throws challenges at us.
Okay, good distinction. Now, okay, in our last minute here, let's get some ideas going forward. What do you feel could improve how our mental health system deals with issues of culture and race?
We could do something really simple and have a plan. We don't have
no
plan.
When you say we, you mean Province of Ontario, or?
Province of Ontario has no plan, the federal government has no plan. We have no plan.
And what should the mission of the plan be?
Well, we might want to know what who we've got here. We might want to know what their needs look like. We might want to know what they might like us with regards to treatment and what treatment is effective. We might want to do something like produce language structures or a language competency strategy, which means that people can actually get services in their language if need be. There are loads of things we can do, but we need a plan. We have no plan.
That's shocking. I mean, how can that be true?
Well, that is true.
Really? I mean, we have a huge, healthcare system and mental health.
It beggars belief for a number of reasons. If you don't have a plan, you'll end up spending more, almost definitely. And on top of that, immigration is the main driver of population growth. And the immigrants are the people who are going to be paying my pension, your pension, everybody else's pension, and keeping us in the lifestyle that we've become accustomed to. If we do not look after them, they will get ill. And instead of being able to look after us, we'll be trying to look after them. We've got to have a plan. If we don't have a plan, things will go wrong.
Okay, Kwame McKenzie, that's day 2. Come back and see us again tomorrow when we continue our journey as we look at the other in our society, all this week on the agenda. Thanks so much.
Thank you very much.